What is the mechanism of action of respiricase? It is a urate oxidase analog that converts uric acid to allantoin. So even after receiving uric acid reducing therapy, patients who are receiving chemotherapy may still develop acute kidney injury due to renal tubular obstruction and direct cellular injury. How are phosphate, uric acid, and potassium levels affected in tumor lysis syndrome? Hyperphosphatemia, hypocalcemia, hyperuricemia, hyperkalemia. What is the next best step in management in a patient who has lumps in the neck 9 weeks after being treated for infectious mononucleosis? Lymph node biopsy. What is the most likely cause of tumor lysis syndrome in a patient that received respiricase? Calcium phosphate precipitation. So, like previously mentioned, respiricase reduces the likelihood of developing acute kidney injury due to renal tubular uric acid precipitation. However, respiricase does not affect the levels of phosphate and calcium. So, acute kidney injury is due to calcium phosphate precipitation in patients who take respiricase. The risk of calcium phosphate stone formation can be reduced by maximizing the GFR and urine output with prophylactic IV fluids. What is first-line treatment for rapid reversal of anticoagulation in patients taking warfarin? Prothrombin complex concentrate. Fresh frozen plasma is considered the second-line therapy for replacing vitamin K-dependent clotting factors. What is used to reverse dabigatran? Recall that dabigatran is a direct thrombin inhibitor, and such drugs are really helpful in treating patients that develop type 2 HIT. So you can reverse dabigatran with this IV drug. What can be used to treat minor bleeding episodes in patients with von Willebrand disease or uremic platelet dysfunction? IV desmopressin. Why is oral codeine and tramadol contraindicated in children less than 12 years old? Ultra-rapid metabolism causes unpredictably high concentration of the active drug in the body. So basically, let's say that you have a patient with sickle cell disease that has an acute pain crisis. And this patient is 8 years old, and you see codeine, tramadol, and hydroxycodeine in the responses or the option choices. You would choose hydroxycodeine or codone because that does not cause the ultra-rapid metabolism that can lead to drug toxicity in children less than 12 years old. However, that can be seen in children less than 12 years old who take oral codeine and tramadol. And note that this drug toxicity can lead to respiratory depression and death in these patients. Is unconjugated or conjugated bilirubin elevated in a newborn with ABO hemolytic disease? Unconjugated hyperbilirubinemia. So this condition typically occurs in infants with A positive or B positive blood type and mothers with O positive blood type. Mothers have antibodies against A and B antigens, causing a hemolytic reaction in the newborn when blood is mixed in the peripartum period. What is the treatment of choice in a newborn with ABO hemolytic disease and indirect bilirubin is 24.1? Exchange transfusion. So in cases of severe hyperbilirubinemia, that's bilirubin greater than 20, patients require aggressive intervention with exchange transfusion. However, in mild to moderate diseases, you can use phototherapy to treat this condition. What is the most likely diagnosis in a 2-month-old with a hemoglobin of 5, macrocytic red blood cells, and absent thumbs? Diamond-Blackman. What is the underlying cause of physiologic anemia of infancy? Transient downregulation of EPO. So the hemoglobin falls from the level at birth to a physiological lower level. This occurs at about 2 to 3 months in term infants. What lab findings are evidence of hemolysis? Anemia, indirect hyperbilirubinemia, low haptoglobin, high LDH. What is the most likely diagnosis in a patient with elevated catecholamine metabolites, NMYC gene amplification, and small round blue cells? Neuroblastoma. Recall that patients with neuroblastoma are typically less than 2 years old. They have a painless abdominal mass that can cross the midline. They can also have periorbital ecchymoses, spinal cord compression from epidural invasion, or opsoclonus myoclonus syndrome. Is the adrenal medulla or adrenal cortex involved in a neuroblastoma? Adrenal medulla. What is the most likely diagnosis in a patient with macrocytic anemia and elevated red blood cell distribution width? Iron deficiency anemia. So if you're supposed to look at a chart with the different lab changes that occur in iron deficiency anemia versus thalassemia, the thing that should stand out to you is that in iron deficiency anemia, it has an elevated red blood cell distribution with extremely high yield. What is the next best step when treating a patient for osteoporosis fails or the disease is rapidly progressive? Seek secondary causes. What is the most likely diagnosis in a patient with HbA and HbS in a 60 to 40 ratio? Sickle cell trait. What is the next best step in a patient taking warfarin who has an INR of 4.3? Hold warfarin 1 or 2 days or decrease the dose. What is the next best step in a patient taking warfarin who has an INR of 5.1? Hold warfarin and resume when INR is therapeutic. Give low-dose oral vitamin K if there is an increased risk of bleeding. What is the next best step in a patient taking warfarin who has an INR of 11.2? Hold warfarin and give high-dose oral vitamin K. What is the next best step in a patient taking warfarin who has serious bleeding? Hold warfarin and give IV vitamin K 10 milligrams and PCC. Inferior vena cava filters double the risk for which condition? Recurrent DVTs. What is the most sensitive imaging modality to diagnose an ocular melanoma? Ultrasound. Radiotherapy is used to treat symptomatic choroidal melanomas. Enucleation is considered for very large tumors or tumors with extrascleral extension. What is the most likely cause of asymmetric lower extremity, deep tendon reflexes, and back pain in a patient with a pancreas tumor? Spinal cord compression. What is the treatment of choice of osteomyelitis in a child with sickle cell disease? Clindamycin and ceftriaxone. So you need gram-positive coverage with nafcillin or cefazolin if the likelihood of MRSA is low, or if the likelihood of MRSA is high, then you go ahead and use clindamycin or vancomycin. You also need gram-negative coverage due to organisms like Salmonella because patients with sickle cell disease have functional asplenia and are vulnerable to encapsulated organisms. So that's why we also use a third-generation cephalosporin like ceftriaxone or cefotoxime for gram-negative coverage. What is an appropriate empiric antibiotic regimen for patients who have sickle cell disease with acute chest syndrome? Azithromycin and ceftriaxone. What is the underlying cause of ITP? Platelet destruction by antiplatelet autoantibodies. So ITP usually occurs after a viral infection, and patients can present with clinical features such as mucosal bleeding, ecchymosis, petechiae, and of course, isolated thrombocytopenia less than 100,000. What is the treatment of choice in a patient with ITP and platelets less than 30,000 or with bleeding? Glucocorticoids, IVIG, or anti-D. What is the treatment of choice in a patient with ITP and cutaneous symptoms only? Observe. What is the preferred anticoagulant in the first trimester? Low molecular weight heparin. So this is not teratogenic in the first trimester. However, recall that you need to avoid this in patients with severe renal insufficiency. What is the preferred anticoagulant in the second to third trimester in a patient with a mechanical heart valve? Unfractionated heparin. Recall that this is quickly reversible with protamine. Also, all anticoagulation is discontinued at the onset of labor due to the risk of hemorrhage and before epidural anesthesia due to the risk of epidural hematoma. Can hemolytic disease of the newborn occur in a Rh positive mom and Rh positive father? No. How is MCV, iron, TIBC, ferritin, and transferrin saturation affected in patients with iron deficiency? All are low except TBIC, which is high. How is MCV, iron, TIBC, ferritin, and transferrin saturation affected in patients with thalassemia? MCV and TIBC are low. Iron and ferritin are high. Transferrin saturation is low or high. How is MCV, iron, TIBC, ferritin, and transferrin saturation affected in patients with anemia of chronic disease? Iron, TIBC, low. Ferritin, high or normal. Transferrin and MCV, low or normal. What is the most common cause of inherited thrombophilia? factor V laden. So other causes of hereditary thrombophilia include prothrombin gene mutation, protein C, protein S or antithrombin 3 deficiency, and hyperhomocystinemia. What is the most sensitive imaging test to detect osteoblastic bone mets of prostate and other cancers? Radioisotope bone scan. So recall that in another condition such as multiple myeloma, where there are lytic bone lesions, you would not use the bone scan. Instead, you would use the X-ray or skeletal survey. What is the most sensitive imaging test to detect osteolytic mets? Plain X-rays and PET. What is the gold standard confirmatory test for type 2 HIT? Serotonin release assay. Recall that you need to start treatment in suspected cases prior to doing any confirmatory tests. What is the treatment of choice of a patient suspected of having type 2 HIT? Stop all heparin products. Start a direct thrombin inhibitor. So HIT should be suspected clinically when patients' platelet counts fall greater than 50% from baseline 5 to 10 days or 5 to 14 days after starting heparin. What are the two major implicated autoantibodies implicated in pernicious anemia? Antiparietal and anti-intrinsic factor antibodies. What are the three main components of autoimmune metaplastic atrophic gastritis? Glandular atrophy, intestinal metaplasia, inflammation. So, pernicious anemia is associated with this condition, and the glandular atrophy is mainly seen or affected in the gastric body and fundus. What test helps in determining the underlying cause of normocytic normochromic anemia? Reticulocyte count. A patient with normocytic normochromic anemia has an elevated reticulocyte count. What is the most likely underlying cause? Hemolysis. You can also see other signs of increased red blood cell destruction, such as increased indirect bilirubin, increased LDH, an enlarged spleen, and a decreased haptoglobin. A patient with normocytic normochromic anemia has a low reticulocyte count. What is the most likely underlying cause? A hypoproliferative state, such as hypothyroidism or aplastic anemia. What is the most common blood transfusion reaction? Febrile non-hemolytic. So this occurs due to cytokine accumulation during blood storage. It typically occurs within 1 to 6 hours after the blood transfusion, and patients present with fever and chills. What is the underlying cause of wheezing and hypotension within a minute of receiving a blood transfusion? Recipient anti-IgA antibodies directed against donor blood IgA. This is seen in IgA deficient patients, and the management includes epinephrine, antihistamines, glucocorticoids, and circulatory and respiratory support. How can a diagnosis of acute hemolytic transfusion reaction be confirmed? Positive direct Coombs test, pink plasma, hemoglobinuria, repeat type and cross match showing a mismatch. How should acute hemolytic transfusion reaction be managed? Stop transfusion,
aggressively hydrate with normal saline.